Welcome to our May webinar, From the Experts, All Things Celiac, hosted by the Celiac Research Center at Harvard Medical School and the National Celiac Association. I'm Lee Graham, Executive Director of the National Celiac Association, founded in 1993. The launch of NCA's Feeding Gluten-Free initiative in response to the need of food pantries has been tremendous. Up to now, we have shipped $640,000 worth of gluten-free food to food pantries in 29 states. Despite this, the need continues. Food pantries tell us that the demand is 2 to 3 times more for gluten-free families than ever before. And we've heard stories about moms and dads skipping meals so their celiac kids can eat gluten-free. Despite the food we continue to deliver, there are so many more families who need our help. I hope you'll consider a donation to this important program. Just go to nationalceliac.org, and thank you in advance. For today, you're welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or by phone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm excited to introduce today's moderator, Dr. Karen Kelly. Dr. Kelly is a professor of medicine at Harvard Medical School and a gastroenterologist at Beth Deaconness Medical Center in Boston, Massachusetts. He has been engaged in patient care and research in celiac disease for more than 30 years. Dr. Kelly is an internationally recognized expert in the diagnosis and management of celiac disease. He is the author of more than 200 medical publications appearing in leading medical and scientific journals. In 2004, he was a founder of the Celiac Center at Beth Deaconness Medical Center and serves as its director. In 2013, he co-founded the Celiac Research and Education Program at Harvard Medical School. Welcome, Dr. Kelly.
Lee, thank you very much for your kind introduction. I didn't like the bit about how many years I've been working in celiac disease. It gives away some state secrets, nonetheless. So thank you, Lee, and thank you to the NCA for partnering with us on this exciting webinar, which is a research roundup where we'll be examining promising novel therapies for celiac disease. Arguably, the most exciting aspect of celiac disease currently is the rising tide of novel therapies being evaluated to augment the gluten-free diet. I believe we'll start with a polling question, Chris. So if a medication for the treatment of celiac disease, either alone or in addition to the gluten-free diet, becomes commercially available, would you consider taking it? Yes, no, maybe, depending on safety, maybe, depending on cost, or this does not apply. For example, you may not have celiac disease. And so we will revisit this question at the end of the presentations. And compare answers before and after to see if, actually here we have the answers. So as regards considering taking such a treatment, the answer yes receives 44% of the votes, and a close second is maybe, depending on safety, which makes a lot of sense. So let me move on to introduce our first speaker. It's a great pleasure to introduce Amelie Therrien, who will give our first presentation. Amelie received her MD degree in 2011 from the University of Montreal and completed her internal medicine residency and then her adult GI fellowship, combined with a clinical scientist program in 2017. She's a fellow of the Royal College of Physicians of Canada in internal medicine, in adult gastroenterology, and as a clinician scientist. She completed a master's degree in experimental medicine with a focus on immunology, working on Crohn's disease in 2018, and then moved to Boston to study celiac disease with me and the Celiac Research Program at Harvard Medical School. Her main areas of expertise are celiac disease, other small bowel disorders, nutrition, and inflammatory bowel disease. She is now working as a gastroenterologist, clinician, and scientist at the Celiac Center at Beth Israel Deaconness Medical Center and as an instructor in medicine at Harvard Medical School. Amelie, it's a pleasure to hear you speaking to us about potential therapeutic targets in celiac disease.
Thank you very much, Dr. Kelly, and I would like to thank NCA for inviting me among this great panel with whom I trained in the last few years. So I do not have any conflict of interest to disclose. Today, we will take a few minutes to discuss what is gluten and what is happening in the intestines in celiac disease. I hope that this way, the audience will be able to understand better how each potential treatment may work for celiac disease. We will discuss the pathophysiology of celiac disease, but not of the other gluten-related disorder, such as non-celiac gluten-wheat sensitivity or complicated celiac disease, such as type 2 refractory celiac disease. Not everyone in the audience has the same scientific background, so the presentation has been simplified to make sure everybody understands. I will be happy to go more in details in the Q&A session. So people with celiac disease should avoid wheat, rye, and barley. These grains are formed of an envelope, the bran, that is good and soluble fibers, a germ, which is the plant embryo, and the endosperm that is all around the germ. The endosperm consists of starch and storage proteins to protect and feed the germ. Among these proteins, prolamine and glutenin are the ones that are considered as gluten. Their name varies according to which grain they are from, with gliadin being the most studied and the most known being from wheat. So why is it called gluten? Because these proteins are like a glue that hold air and water and give the dough its elasticity and extensibility. This is why it is super popular in the baking industry and why we may have issues having nice fluffy bread and pastries with our gluten-free flours. Gluten is then in the family of proteins and not a starch. Proteins are long 3D sequence of amino acids. They can be cleaved by enzymes in peptides with our shorter chains of amino acid and in individual amino acids. How are proteins usually digested? So it started in the stomach. The acidity of the stomach and an enzyme, pepsin, break the proteins from a 3D configuration to peptide segment. However, some bonds between the amino acids that form gluten are too strong to be broken. So you have the protein that becomes polypeptide chain by the effect of the acidity and pepsin, and then some other enzymes in the intestine, such as trypsin and chymotrypsin, break the peptide further into tripeptide, dipeptide, and amino acid. The gluten peptides are not breaking down like this, as you can see on the right part of the slide. So instead of being digested and absorbed as dipeptides and amino acid like other proteins, gluten has long peptides in the small intestine. So human enzymes like normal pancreatic enzymes cannot digest well the gluten. This is not specific to celiac disease, and no human is able to properly digest the gluten. A large proportion of gluten peptides ends up excreted in the stools. So the tests that are detecting gluten in the stools show whether or not the person had gluten in his diet and is not a diagnostic test for celiac disease. Anyone who eats gluten will have gluten in their stools. The next concept I want to explain is the tight junctions. So intestinal cells and enterocytes are attached to each other by little velcros that are commonly called in the scientific community tight junctions. It forms a barrier preventing some bacteria and toxins to be absorbed and circulate into our bodies. However, there are multiple factors and disease that can loosen the velcros and it increases the intestinal permeability. So this way, some of the gluten peptides that are in the intestinal lumen can be absorbed and enter in the circulation. This is also why anyone eating gluten will have gluten peptides in the urine. This is not specific to celiac disease neither. The last concept I would like to explain is tissue transglutaminase, or TTG. Some people in this audience with people in this audience with celiac disease are having blood work where we look for the presence of antibodies against the TTG. But what does TTG do? It is an enzyme present in the lower border of the intestinal cell. So in this presentation, it's like pictured as the blue triangle here. The enzyme gets activated when there is cellular stress. And in the particular example of gluten, it modifies one of the amino acid, the glutamine. Everybody has TTG in their intestine, independently of having celiac disease or not. And theoretically, anybody could modify the gluten when the TTG gets activated. So what happens in someone with celiac disease? So multiple evidence show that there is increased intestinal permeability in active celiac disease. So the velcros between the cells are not well tied together. The gluten peptide get easily absorbed through these loose bonds. We have these gluten peptides are then processed or deamidated, as we say in the scientific community, by the transglutaminase. So we all have immune cells that have little antennas that are called HLA, and they catch peptides that look suspicious as intruder and present them to the other immune cells. These cells are called antigen-presenting cells. People with celiac disease have HLA DQ2 or DQ8 that are compatible with the sequence of the gluten peptide processed by the transglutaminase. This HLA is also commonly found in people without celiac disease. So it is not what caused the disease per se. In other words, if someone carries a HLA DQ2 or DQ8, it doesn't mean that the person has celiac disease. There are also pro-inflammatory that are pictured as red cells in the presentation, and regulatory immune cells that are pictured as green cells in the presentation in everybody's intestine. Depending on the type of messages the cells are sending to each other and previous experiences, the response to an intruder can either be to attack with the red cells, pro-inflammatory, or to tolerate with the green cells. People with celiac disease have gluten-specific pro-inflammatory cells that have also antennas that are called TCR that fit with the sequence of gluten. So to have pro-inflammatory cells with receptor compatible with gluten is specific to celiac disease, and to my knowledge, it is not present in people without celiac disease. In individuals without celiac disease, gluten is tolerated, even if the person is carrying a HLA DQ2 or DQ8. However, in people with celiac disease, there is a loss of immune tolerance. So immune cells identify the gluten processed by transglutaminase as an intruder. It leads to an inflammatory response, and the gluten-specific T cells are amplified. So they are all brought into the small intestine, all the red cells that are depicted in this presentation. And there is production of antibodies against the tissue transglutaminase and the gluten. And there are other cytokines that I like to picture as arrows that attack the intestine and that can attract more immune cells. And some of those cytokines that are now renowned in celiac disease are IL-15. Interleukin-15 has the property of making the cells like immortal, or interleukin-2. So to summarize, with the title of my presentation being the potential targets of therapy. So what we discussed is that gluten is a protein that is not well digested by the human gastrointestinal tract. So one potential target could be to better digest the gluten so it becomes inoffensive. But it cannot come from enzymes that are naturally present in the human species. So we have to design or take enzyme from other species that are able to digest the gluten. Gluten can cause stress to the intestines in people with celiac disease and gets absorbed through loose tight junctions, so loose velcros between the cells. So another target could be to fortify these tight junctions so the gluten get less absorbed. Gluten gets processed by an enzyme, the TTG, at the bottom of the cells that makes the undigested peptide sequence match with the antennas like the HLA and the TCR in the immune system. So two other potential targets could either be to block the TTG from processing the gluten or block the binding of gluten with the HLA so it gets not like presented to the immune system. There is a loss of tolerance, so more pro-inflammatory cells instead of Tregs, and gluten is seen as an intruder. So another therapeutic target could be to teach the immune system to tolerate the gluten. And finally, there is an inflammatory response with antibodies like cytokines, arrows, and other corrosive substances that eventually kill the intestinal cells and cause like the villus atrophy that is commonly found in celiac disease. So one final target could be to block these cytokines to try to avoid some recruitment from more immune cells into the intestine or reduce their inflammatory properties. So I would like to thank you for your attention, and I hope you enjoy the rest of the webinar.
Amelie, thank you for a wonderfully clear dissection of the reaction of people with celiac disease to gluten and the therapeutic targets that unveils. Our next speaker is Jocelyn Silvester. Jocelyn is Assistant Professor of Pediatrics at Harvard Medical School. She's an MD, PhD. She's also Director of Research for the Celiac Disease Program at Boston Children's Hospital. She's an associate staff member at Beth Deaconness Medical Center. She also maintains a general pediatric practice in northern Manitoba and Nunavut, Ongo Meeswin, if I pronounced that halfway correctly, Health Services with the J.A. Hildes North Medical Unit. Jocelyn is co-chair of the North American Society of Pediatric Gastroenterology, Hepatology and Nutrition, Celiac Disease Special Interest Group, and she serves on the American Gastroenterological Association Council for Section on Basic and Clinical Intestinal Disorders. Her research interests include the diagnosis and management of celiac disease, with a focus on what happens after the diagnosis of celiac disease is made. She's a co-investigator on the Manitoba Celiac Disease Cohort Study, involved in clinical trials for alternative therapies to a gluten-free diet, and she is leading a consortium of pediatric celiac centers across the entire United States to develop better tools to improve follow-up and care. Jocelyn, we look forward to hearing you speak to us on how to get a drug approved for celiac disease.
Thank you very much, Kieran. It's great to be here. And I'm happy that we have some time to talk about this. This is one of the things that we never seem to get to when people ask me questions in clinic. I think the most common question I'll get asked is there a drug for celiac disease? And then when are we going to get the drug? And so I want to talk a little bit about how, which answers some of the questions about when. And so to start off with some disclosures, and I think the key things about disclosures are it means there's people who are interested in celiac disease, which is fantastic. And it also brings up the point that this is really a partnership, and there's many people who are going to be involved in helping us get a drug. And we'll see this as we look through what is involved in the process. So to start off with, we all know where a drug comes from, and that's a good idea. And Dr. Therrien just did a very good job of outlining some of the potential ideas of what one might try and do in order to treat celiac disease. And so if we think about these ideas in really broad categories, there's really two different options, and there's drugs that are being developed for each of these options. One would be to address the problem we know that a gluten-free diet still contains gluten, and even though people try to avoid gluten, gluten has a way of finding people. And so is there a way we can make the gluten-free diet more gluten-free? Is there a way we can help digest that gluten so it doesn't become a problem? Another option would be to allow what I'm going to call a, quote, normal diet, which means a diet that contains gluten. And so can you have your celiac disease, have your medicine, and have your cake and croissants too? And so this might be something where you get rid of those pro-inflammatory T cells and you have more of these regulatory T cells that don't cause damage. And so these are two different types of drugs, different ideas that would be tested in slightly different ways. So either way, the first step to getting this idea into a treatment doesn't start with people. It actually starts in the lab. And there's actually a lot of work that can be done either using isolated proteins. For instance, you could isolate an enzyme or cell lines. Maybe you could look at the effect of something on intestinal cells before you look at a person, or you could look at an animal model. And even there's ways that you can model things in the computer to get an idea of what's going on and how your drug might work before you actually start testing it. I should note here that one of the challenges and one of the things that's unique about celiac disease is that there's not fantastic animal models. And so that's one of the things that makes celiac disease perhaps more challenging than other diseases where there's models that are pretty good representatives of the disease. So that's affected what types of drugs have been developed and how they can be tested before they go into humans. So once there's a body of evidence that this drug appears to work and what it might do, then this is when whoever wants to develop the drug can move from what we call this early preclinical phase in the lab to the clinical phase. And really what starts this process is something called an IND, or an investigational new drug application. And the idea here is that the party that wants to see if they can take this lab work and make it a drug gathers their data together. They have a plan for how they're going to make the drug, and they have a plan for how they're going to test the drug to see if it works. And this information is submitted to the FDA, the Food and Drug Association Administration, because they are the folks who give approval to drugs in the United States. And they may have some feedback, they may ask for changes, and ultimately, once that's approved, that's the green light that these trials can start and that the drug can start to be tested in humans. And so this is, I should note here, I think there's been more interest in the drug approval process in the last 12 months as we've all been eagerly watching COVID vaccines. And this is really the same process because it's really universal, whether you're treating celiac disease or an infection. And so what is the FDA looking for? And so one of the things that's most important and is somewhat intuitive, but has a big impact on how you design your studies is the FDA wants a drug that is going to be beneficial in terms of how an individual feels, functions, or survives. And of course, the benefits should outweigh the risk. And they want to know how this compares to existing treatments. And so in celiac disease, this would be a comparison to a gluten-free diet. Now, you'll notice this is really how the person feels, and there's nothing here about how tall their villi are, which is important because that affects how studies are designed. And really, to get approval in the United States, the most important thing is what's called PROs, or patient-reported outcomes. And these are really ways of finding out how the patient is feeling, how they're functioning. And fortunately, in celiac disease, we don't look at survival as much because our patients survive. And so any study is going to have lots of questions and often repetitive questions asking about symptoms so that there can be some monitoring of what the change in symptoms are. Now, before we look at the steps in the process, there's a few things that make celiac disease arguably unique and things that are challenges, but hopefully not barriers to getting a drug. And the first one is, what's the best patient-reported outcome? So there's different symptoms of celiac disease. So some people who have headaches, they aren't going to report diarrhea. But then we also have a lot of patients with celiac disease who really are asymptomatic. So how do you show that somebody who's asymptomatic is feeling, functioning, or surviving better? I think that's a challenge that we're going to have to overcome. Another challenge, which I think we're slowly overcoming, is the idea that a gluten-free diet is safe, it's cost-effective, it doesn't have a lot of adverse effects, and so why do you even need a drug for celiac disease? And I think we saw already that this is an audience that understands that a gluten-free diet is perhaps safe, although it does potentially put you at risk for nutrient deficiencies whenever you take something out of your diet. It's definitely not easy, and there's a huge psychosocial cost of following a gluten-free diet. And it's cost effective from the point of view of insurers because they're not paying for gluten-free food. And so I think these are barriers that can be overcome, but have historically been reasons why people have maybe been less enthusiastic to make drugs for celiac disease. Another challenge is that we're increasingly recognizing that as much as people with celiac disease on a gluten-free diet try and avoid gluten, gluten is everywhere, and eventually it will find them, sometimes in smaller quantities, sometimes in larger quantities. And so how do you study people on a gluten-free diet when that includes sprinkles of gluten here and there? And so that's a more theoretical obstacle that needs to be overcome. And then I think one of the bigger things that we'll talk about at the end is if the treatment is an alternative to a gluten-free diet, then the only way to know if it works is to give people with celiac disease gluten. And this is often a group of people who've been told for years and years that they shouldn't be eating gluten, and now we're asking them to eat gluten. And it also means that unlike a condition such as cancer, where often there's potentially a benefit of the treatment and not necessarily a harm of the placebo, in celiac disease, if everybody has to do the gluten challenge, then those people who get placebo, they may actually get worse from participating in a clinical trial. And often clinical trials are seen as a potential for treatment to make people better. So I think that's unique to celiac disease, but not a reason not to do it, because there's definitely benefits. So when we think about drugs, the things we want to know, first of all, are safety. And so how do we look for safety of a drug? There's some simple ways to check up on organs. So often there'll be blood tests to check up on the kidney, check up on the liver. All those animal studies that are done, sometimes they may find a signal that some of the animals who got really high doses, maybe they had a heart problem, so they might want to do an EKG to look at the heart rhythm, to take an extra look at the heart. Any organ system, you could potentially have extra tests. And then you can look at the actual celiac disease potentially to make sure that's not getting worse from the treatment, either by doing a pill camera or potentially a biopsy. And so safety comes first. But it doesn't matter how safe something is if it doesn't work. And so efficacy is the other thing that's important to show in a clinical trial. And this is done primarily by these patient-reported outcomes because the patients know how they're feeling and functioning, and they have to tell the researchers so that they can know if the drug is improving that. And then there's so-called secondary or surrogate endpoints, such as blood tests or potentially a biopsy, but I haven't had a patient in clinic yet who tells me that their villi are slightly taller and they're feeling better. And so looking at villi isn't going to be the way that we can get a drug approved for celiac disease. So here's an overview of the process. So we've done our lab studies, we've done the toxicology, we have some idea of how it affects the body, some idea of the dose in animals, often rodents. And this has been put together. There's an IND, investigational new drug, with a plan of a series of trials, which are conveniently numbered phase 1, phase 2, phase 3. And the point here is to first check the safety and then the efficacy. And then in phase 3, really figure out not only what's the safety and what's the efficacy, but who is this drug for and what does this drug do? Is this a drug for people when they're diagnosed as an alternative to a gluten-free diet? Is this a drug for people who are still having symptoms on a gluten-free diet to help their diet be more gluten-free? And so the type of people who are in a phase 3 trial is going to determine what the indications are and who's the drug is for. But we're going to start over here in phase 1. And once you get through the phases, then you have a drug. And this is somewhat simple, but it actually is called in pharma, they often refer to this as the valley of death, because there's a big gap between having something that looks good in animals and having something that's being proven safe and effective and that the FDA is going to approve. So this is often called the valley of death because there's lots of lions and tigers and bears that can get the drug, and there can be problems that show up along the way. So what's the first step? The first step is safety. Usually this is done in healthy volunteers, and usually it's done in a few dozen or dozens of people. It's a small number of people. It's usually started at a low dose and then stepped up as it's tolerated, and really looking to see how the drug's absorbed and what are the side effects. On the bottom here are some estimates of how much it costs for each of these phases, remembering, of course, that most drugs are going to fail. In fact, if we take 50 drugs that enter into phase 1, and each of these has the green light, they've gotten their IND. Once the phase 1 trials are finished, 15%, so 7 or 8 of these drugs are going to pass and be able to go on to phase 2. So phase 2 is going to be, how does this drug work? And knowing that it's safe, some of the big signals you get with a small number of patients. And in order to know if it works, often you need more patients. So these tend to be bigger trials, they tend to be longer trials, and it tends to cost more money. And so one thing is to have a good outcome in your phase 1 trial. Another thing is to raise all the money you need for phase 2 so that you can even get the study done. And so these are studies where for celiac disease, often there's going to be a visit to make sure that you're the right type of person for the study, and then maybe an observation period, and you may or may not get the drug, and then looking at different things such as maybe an endoscopy, some blood work to see how the drug is affecting you. And of course, lots and lots and lots of surveys, because we really need to know how people are functioning to know how the drug is working. And so if we think about those medications we had that were successful after phase 1, we know a little bit more about these compounds. And so about 20% or 1 in 5 are going to be successful in phase 2 and be able to go on to phase 3. So out of 50 shots at having a medication for celiac disease, we could expect that maybe 2 of those would be able to go to a phase 3 trial. And so the phase 3 studies are the bigger studies, and they're the more specifically defined studies. And now you have typically thousands, hundreds, often thousands of patients, and you're looking at hundreds of millions of dollars. And so if we take a step back from celiac disease and think about something like the coronavirus vaccine, in phase 1 trials, there were dozens of patients. Phase 2, there were hundreds. In phase 3, some of these trials had tens of thousands of patients. And they started with adults, which is why initially the vaccines were approved with adults. And then as they did trials in different populations, they could get an indication for pediatrics. And so this is part of the reason why you may have multiple phase 3 studies to get your drug through for different people, and why sometimes drugs come out first in adults and then later on are available for children. So phase 3 studies, we've got 2 of our 50 drugs left. And the good news is that it's estimated, if you look at overall drug development, about 50% of the drugs that are in phase 3 are eventually going to get an approval. So out of 50 tries, hopefully one's going to hit the bullseye. And for drug approval, that means getting a new drug authorization, being prescribable, and being able to get into the hands of patients. Now, as we've learned, I think again here, coronavirus is a good example. We've learned that there are things that you may not pick up in these trials because they're very rare events. And so often the FDA may ask for more. And so there's a phase 4 called a post-marketing phase, which is usually related to safety. And so this may be a surveillance program, or it might be that the FDA asks for more studies looking at a specific population. So this drug is available, but there's still more work going on. And even once drugs are approved, there's still ways to report adverse effects. So there's always ways of feeding back if there's a safety signal. And I think we've seen that very effectively, how that works with the coronavirus vaccines. We don't know what the safety signals will be necessarily for celiac disease, but the system is able to accommodate looking for the safety signals, and we'll discover them as we go through the process. So this is, in a nutshell, how you go from that great idea to make gluten more digestible, to showing in a test tube that your enzyme can digest gluten, to showing that it doesn't make your rats sick and they're able to digest it, to showing it doesn't make humans sick, to showing that it works, to showing that people who still have gluten in their diets feel better when you get the enzyme, for instance. So that would be an example of how you might go through these trials. So The next question I often get in clinic after people ask me, how long is it going to be for a drug? And as you can see, these take many years. Part of the reason it was faster for COVID is that they didn't finish phase 1 before they started phase 2. So if you do these things overlapping, you can shorten your timelines a little bit. They also had some help on the funding end, which is also very important. So the next question I often get asked is, what can I do and how can I help? And I think what's really important to remember is that there's lots of aspects of this process, and really the actual people who actually take the drug or placebo in a clinical trial are a small portion of all the volunteers that go towards being able to get a drug approved. Remember, we talked about these patient-reported outcomes. How we determine what the patient-reported outcome should be is we have to find out from patients is what the important symptoms are and what the important outcomes are. So focus groups and surveys are one way that we can develop tools in order to have a clinical trial. Sometimes you may be asked for blood samples, which can be used to do various testing or to learn more about how celiac disease works, to learn more about what a potential target for a drug would be. Sometimes you may be asked for an extra biopsy, or in a study, there may be a biopsy. And then once you get into clinical trials, this is where you're going to be asked to take a medication or placebo. And for at least some of these studies, you may be asked to eat gluten. And this is where usually my patients are a little bit skeptical, because I spend most of my time telling them they should be avoiding gluten. And so I get asked, why should I eat gluten for science? And I think this is a really important question that is worth thinking about a little bit. And I think the bottom line is that if we have a medication that's going to replace a gluten-free diet, the only way that we know that it works is to have somebody take the drug and eat gluten. And there's no way to be on a gluten-free diet and test a drug and know that that drug lets you eat gluten. So why is this okay if in clinic we're saying, avoid gluten, don't eat gluten on purpose? And I think there's a few key reasons. The first one is that we know, and it's very clear, that gluten damage is reversible. So if you eat gluten, yes, if you have celiac disease, it's going to damage your villi, but those villi are able to grow back and able to recover. And so this is a big reason why it's safe to do these studies, is because there's a balance between the risk and the benefits. And we know that once you treat people with celiac disease, they get better. And it's the same if you put them in a clinical trial. Another thing is, when you volunteer for a study, often you will be asked maybe 15, 20 questions about, do you have this condition? Do you have that condition? And the reason for that is that there is a selection process to try and make sure that the people who are involved are not those who may be at higher risk of complications. As well, I think it's important to remember that while you may be asked to eat gluten, how much gluten may depend on what the drug does. And so if this is a drug that is for people who may be getting extra gluten exposure from their diet, but there's no known things they're having gluten, then it might be that you're being asked to have small amounts of gluten that in most people don't induce symptoms. If this is a drug instead of a gluten-free diet, then you may well be asked to have a massive meal of gluten. And so the amount of gluten in the study is going to be tailored to what the drug is intended for. That's why there's a target population in these studies, and it's going to be tailored to how the drug works. And as investigators, one of the things that we're very keen to do is minimize how much exposure our patients have to gluten. And this is part of the reason why we spend a lot of time thinking about this in study design and doing studies to find out what's the best way to monitor reactions to gluten without needing a lot of gluten. In some studies, there may be an option to decrease the dose, and in some studies, there may be ways that there's so-called rescue medications to help if people are having symptoms that are more severe. So I think these are all reasons to eat gluten for science. The title of my talk is How Do We Cross the Valley of Death? Because this is a team effort, and the most important people are not the pharmaceutical companies, they're not the scientists, they're the patients and the volunteers. And so the most important part of the team is you, and that is really what all of this hinges upon. So hopefully together will get a treatment for celiac disease. And I'd like to tell you what the time frame of that is, but most of the things that are being looked at are sufficiently early that it's really hard to predict. And we know that even though there's things that are in later phases, that's not a 100% guarantee of success. So I think what's exciting is we talk about the pipeline for drugs, how many drugs are there, and that's definitely getting bigger. So we're taking more shots at the target and we understand celiac disease better. So hopefully we're more likely to get that bullseye that gets approved. But when is still a matter of debate. So thank you for the opportunity to speak, and I look forward to answering any questions that people may have.
Jocelyn, thank you for that wonderful discussion on the challenges and the opportunities of developing non-dietary therapies and how to cross the valley of death, as you put it. I like that phrase. Our next speaker is Alessio Fasano. As many of you know, Alessio is a world-renowned pediatric gastroenterologist, research scientist, and entrepreneur. He directs the Center for Celiac Research and Treatment at Massachusetts General Hospital for Children. He is also the Division Chief of Pediatric Gastroenterology and Nutrition, and he is the Director of the Mucosal Immunology and Biology Research Center at Massachusetts General Hospital for Children. He's a professor of pediatrics at Harvard Medical School and professor of nutrition at the Harvard T.H. Chan School of Public Health. Dr. Fasano is author of Gluten Freedom, a book for general readers about celiac disease, gluten-related disorders, and the gluten-free diet. And more recently, he's co-author of Gut Feelings, The Microbiome and Our Health, which was published in March of this year by MIT Press. Alessio.
Thank you, Karen, for the introduction, and thank you again for the invitation. My last, task here is to rationalize what we heard for the first two lectures to really bring this home and try to understand what is really in the pipeline. So these are my conflict of interest. We're not going to discuss any of those in this stage here. And, let's go back to what you heard from Amelie and Jocelyn. Why we even have to bother to, go for something alternative to the gluten-free diet. So far we always were under the impression it's safe, it's efficacious, and so on and so forth. So here are the pros and cons of the gluten-free diet. It's very efficacious, and except for a certain percentage of people, it's safe in terms of no side effects, but socially difficult, sometimes impossible to implement. Is not pharmacological, so there is not a drug that you have to take, but it's not covered by the health insurance. It's self-prescribed and self-administered, so you don't need, to go to the doctor or healthcare professional, but, there is minimal medical support because of that. And as we know, unfortunately, who leaves this on our own shoulders, it's poorly regulated sometimes. It's a treatment for celiac disease, but there is definitely no other alternatives. It's life-saving, but it's a high burden of treatment. These are the word of wisdom that Karen actually put together for us and tries to summarize what are the pros and cons of this diet. So definitely we want to just be, aware that at least, as Jocelyn said, we would like something complementary to the gluten-free diet so that we have a safety net to prevent accidental exposure to gluten, and ultimately the holy grail to have something an alternative to it. So the real story is that now that we have epidemiological data that's a little bit more in depth, will tell us the efficacy of the gluten-free diet. We know that 30% of patients with celiac disease have persistent signs and or symptoms after a year of gluten-free diet. So, sometimes these persistent symptoms are in the category of no response to celiac disease. In other words, people that because of continued cross-contamination, they continue to fuel the inflammation. And then there is the refractory celiac disease that, for the purpose of this discussion, we're not going to cover, as Amelie mentioned before. The other thing is that more than 40% of adults on a gluten-free diet, they have, even without symptoms, a villus atrophy that clearly say that something is going wrong with inflammation after 2 to 5 years on a gluten-free diet. And we know now that this is not, only in adults, but we see similar numbers, even in less magnitude, but even more concerning in the pediatric population, because now we have a growing body that needs, nutrients also to grow other than for the day-to-day activities. In particular for the gluten-free diet, besides the challenges that's related to proper compliance, kids and adolescents particularly, they face additional challenges, including, the vacationing in and out, pediatric patients that have this, unique challenges like birthday parties, school lunch, sleepovers, peer pressure because you don't need to look different than others, lack of appreciation of what's going to happen to you long term if you do something stupid now, and transition to college lifestyle, which pizza and beer are the way to survive. But, if you go and ask the satisfaction, and the first poll that we put out there today is very telling, I have to say, how satisfied is with the treatment of the gluten-free diet for your celiac disease. There is very little doubts that there are only a few people that there seems to be totally fine. We're talking about, 20, 25%. 75%, they believe that this is average or below. And if you look at, the number of people that eventually are cross-contaminated, intentionally or, accidentally, we're talking about the vast majority of people with celiac disease. So easy to say, very difficult to implement on paper if we want to preserve quality of life, meaning doing stuff that many other people is able to do. Again, vacationing, eating out and sleepovers and so on and so forth. The problem that we face when we talk about, the efficacy of the gluten-free diet, if you think about the ultimate problem, so in other words, the inflammation of the gut with the autoimmune insult that leads to villus atrophy, there is no correlation between symptoms and serology with that. So in other words, this is not predictable if you have symptoms or not, if your antibodies are elevated or not, on the fact that there is a heal of the gut, inflammation or not. And why there is, all this, and what is the, the options that we have, current and future, that, we can decrease the burden of this, chronic, lifelong gluten-free diet, and eventually the comorbidity that can come along if not properly treated with a gluten-free diet. What we have right now are very limited options. We have the gluten contamination elimination diet for avoiding the cross-contamination that keep fueling the inflammation. We have, local steroids in the GI tract like budesonide, but that's pretty much it. And then we have possible future options that we can review, very quickly, that are in the pipeline. So what would be the best indication for therapeutics other than gluten-free diet? First and foremost, treatment of those with ongoing signs and symptoms of the celiac disease despite being compliant on a gluten-free diet. So non-responsive, and again, the refractory type 1 and 2 that we're not going to cover today, but there are some stuff that's going on there as well. Adjuvant therapies for patients feeling well. So in other words, I want the safety net. I'm doing great on a gluten-free diet, but every single time that I travel, I go with friends' place, God knows why and what's going on there. But no matter how scrutinizing I'm, reviewing the diet, I'll keep being cross-contaminated. Or again, you don't want to take the risk. You go to college and you want to make sure that even if you eat the salad bar, nobody's cross-contaminated there, or you're doing fine. Replacing the gluten-free diet instead of, that's the second option that Jocelyn was covering, is something that will be extremely helpful, particularly in a subgroup of individuals. For example, the people that have comorbidity between celiac disease and type 1 diabetes. You already have to be on a very restricted diet with type 1 diabetes. Now, on top of that, you have to be gluten-free. The two, in general, they don't see eye to eye in terms of glycemic index and so on and so forth. The Holy Grail, I'm going to touch very briefly on, is to prevent celiac disease. So somebody is genetically predisposed to see if we can intercept the disease. One thing that I want to make sure is that for those that go online and see this products like gluten guest, this other stuff and so on and so forth, the promise that you can eat gluten No problem, because these pills will take care of it. These treatments are not validated. That scrutiny that the Food and Drug Administration, wants to go through, that Jocelyn so clearly spelled it out, are there for a reason, to make sure that these products are safe first and foremost, and they are efficacious in doing what they claim to do. These folks here not being through this scrutiny, so to not be used. So where are the alternative and integrated, treatment to the gluten-free diet? Prevention, primary prevention, that I'm going to touch very briefly. And so the alternative treatment are now in the pipeline that we're going to review briefly. So I'm presenting the scheme just to revisit what Amelie just told us in terms of what are the steps from the time in which you eat a bun to the time in which your gut got inflamed that are in the pipeline, that now we have understanding, thanks to some science and knowledge, that you need to really materialize the celiac enteropathy with the symptoms. Those are the steps that you see in yellow in number 1, number 2, number 3, and so on and so forth, that we are targeting for possible intervention for eventually disarm gluten and create the problem. So if you go to this website, that by the way is publicly available, everybody can go, clinicaltrials.gov, and put as a keyword celiac disease, you will find in real time all the registered clinical trials. You can't publish anything that has to do with a clinical trial unless it's registered on this website. So everything that is going on has to be registered there. There are roughly 260 trials registered for celiac disease. Unthinkable until the recent past. If you think that before 2005, 2006, there was no clinical trial in celiac disease. So the ones that are interesting to us are the under 81 interventional, that will be on celiac disease, that will be 150. And, the dietary intervention, we're not going to talk about that. We're going to touch on some of the 6 prevention treatment. But, what I want to focus on is mainly on the 112 pharmacological intervention that have been in the pipeline. So you look at the map worldwide, where the studies are occurring. I've told in the chat already, if I live in Texas, can I participate? The answer is absolutely yes, because they happen everywhere in the world, the vast majority Europe and the United States, and within the United States, almost every state, there are ongoing clinical trials. So clearly there is a possibility to participate no matter where you live in the US. You heard already of the phases of the clinical trial. In general, phase 1 involves healthy individuals, and that's the reason why it's safety. Phase 2, particularly early phase 2, may eventually require a gluten challenge that, Jocelyn went through. And therefore, you have to voluntarily expose to gluten and see if, whatever drug you're going to take will be efficacious to mitigate what gluten exposure will do. But the most advanced phases, phase 2B and phase 3, are the ones in which they do real life. So in other words, people that, again, are on a gluten-free diet, they are complying with the diet, and yet they're not doing well. Those are the people that are recruited at the most advanced phases, phase 2B, phase 3, and so on and so forth. As Jocelyn said, the more you go in advanced phase, the more failure you have. So it's not surprising. In the early phase, there are larger numbers of trials that are ongoing, and the more you go to the phase 3, the less trials are ongoing. As a matter of fact, there is only 1 trial in phase 3 right now. However, this is a snapshot of the same scheme that I show you of the possible different spots in which you see, different intervention and so on and so forth. 2010, 2021, a plethora, an exponential increase of attention from the, companies to really focus on celiac disease, because now there is the appreciation. This is not just a scientific exercise. There is rather a true need, clinically speaking, to have something alternative or complementary to the gluten-free diet to improve the quality of life for people that live with this condition. Technically, they can be divided in different categories. Steroids, so in other words, that will go after the consequence, i.e. the inflammation, and not the cause of the problem. And I've mentioned budesonide. The enzymes that Amelie mentioned that we don't have, but some bacteria they do, that can dismantle completely gluten, and they are the glutenases. And there are several ongoing trials there, some that stop, some that keep going. Gut barrier, that is this zonal antagonist, that is the one in the phase 3. Then there are immunomodulators that, again, are trying to put this brake on the inflammatory process. There is a vaccine that, the first reiteration actually failed, but there are some revitalization of the idea. The immunosuppressant, that is the largest group, are mainly indicated for refractory celiac disease. There, the disease goes in automatic. Gluten is not a factor anymore. So target gluten, or what gluten does to the intestine, is immaterial. So you definitely need to go after the inflammation. And therefore, they are, definitely worthwhile in terms of cost-benefit ratio, because they, with refractory, particularly refractory 2, there is nothing that you can do in terms of treatment, and therefore immunosuppressant and biologics that can have, important side effects. Still, the return on investment is good enough to consider them. Then there are enzyme cocktails, inhibitor of the transglutaminases, blockers of the HLA-DQ2, probiotics, gluten sequestration. These are all techniques that are in the early stage of development. So they are all either just coming in the pipeline of clinical trial, or barely getting there. So what are the home take messages here? That the gluten-free diet is not efficacious as we thought before. So definitely this is not just a scientific exercise. This is really needed to improve quality of life for people. The burden of treating patients with celiac disease is high. And, a lot of people, they want a treatment option beyond the gluten-free diet. Probably the first agents will be adjuvant to the gluten-free diet, but ultimately is a cure or a prevention. Speaking of which, very briefly, I want to discuss, a few things that are happening for the next generation. Our, kids, the grandkids that will eventually be at higher risk because we do have celiac disease. Now we know from the understanding a little bit more how you develop celiac disease. The genes are important, exposure to gluten are important, but they are not sufficient. They are absolutely necessary, but there's something else that's going on. And among the other stuff, the microbiome, so in other words, the gut, microflora, with this ecosystem, the living in symbiotic relationship with us, seems to make a huge difference if you can switch from genetic predisposition to clinical outcome. In other words, it's the microbiome that switch on and off the genes that eventually control tolerance or immune response to gluten. And therefore, there is a lot of attention to try to figure out what kind of changes in this ecosystem occurs even before the disease onset, so that we can intercept and re-establish a friendly relationship with this microbiome that live in symbiotic relationship with us. This is achieved through very complex and long studies like the celiac disease, genome, environment, microbiome, and metabolism study, the CDGEM, very advanced stage right now. We have been recruited, already 500 kids. We had a first paper that was published, a while ago that, revealed some of the early stage situation, and, including, what the breastfeeding and, I suppose antibiotics or, eventually, other, environmental factors may impinge on the, trajectory of the maturation and engraftment of the microbiome. And now we have also a paper that was just accepted to PNS yesterday night, in which in a longitudinal analysis, these cases identify specific species, pathways, and metabolites that increase way before the onset of the disease. It's like to have a crystal ball so you can see what is happening in the future. And therefore, this will eventually serve as a biomarker for possible future autoimmune disease, in this case, celiac disease, but probably other heart conditions. But most importantly, as possible target for intervention, for disease interception, so that switch that is off, or the genes that puts you at risk to develop celiac disease, will stay off and would not be turned on. I'm going to finish by, again, thanking the entire crew and BRC and all the funding agencies, and of course, this unbelievable, group of a talented individual that I had the pleasure to work with not only here at MGH, but Beth and the Boston Children, because again, it takes a village to do this kind of stuff. And, I am very convinced that the future is that in this village will be always more and more a active participation of the patients and rather to work and, have, a passive role in interacting with what is the future of celiac disease, will take leadership and will make this part of their own syndicate, so they will take care of their future. So with that, I will stop.
Thank you, Alessio. That was a wonderful discussion, and many things were striking, and we'll return perhaps to some of them in the quick Q&A session. But perhaps what strikes me most is the explosion of interest in drug development in celiac disease. And you presented data on that in a couple of different ways, and it's really very striking. If we were having this conversation 10 years ago, there'd be much less to say about actual drug development. It'd be all entirely theoretical. So, Chris, can we return to the poll? And so this is the same poll as previously, and I just invite people to answer the poll similarly or different to the way you answered it last time. Your choice entirely. Good. So can we see the results of the prior poll also? This is the prior poll, I think, or maybe simply the answers are identical, that a majority on both polls answered yes to the possibility of considering taking a new drug for celiac disease, with the second most common consideration that they might, depending on how safe the agent was. So let us now turn to some questions. Sorry. Let's now turn to some questions. So I should explain that we had pre-submitted questions from many of the participants. Thank you for sending those in. And if we have time, we'll also deal with some of the questions that have come in during the talks. So Amelie, let me begin with you. Amelie, there's a question: is 65 too old to be in a clinical trial, or is there an upper age limit?
No, absolutely not. And I saw in the Q&A section also a question about 75 years old as being too old. So first, we would like to encourage anyone who is interested in participating in research in celiac disease to reach out. It is important to study medications in all ages group. And also with age, people can be semi-retired or retired and have more time to participate in studies that require multiple visits. However, I would say that it will depend on the type of clinical trials. So as Dr. Silvester explained, there are different phases. And for instance, phases 1 are in part used to evaluate the safety of the medication. So we prefer to have healthy volunteer. And if the medication could have a theoretical risk for, let's say, the kidneys or the liver, sometimes an adverse event may have a stronger consequence on someone that is older than younger. So this is why some trials may have a threshold for age, but we will definitely encourage anyone to reach out to participate in studies.
Good. And Jocelyn, can you address the opposite end of the spectrum? Is it possible for a 6-year-old or a 16-year-old to participate in clinical trials in celiac disease?
Yes. So I think clinical studies and clinical trials are a bit different. And so there's fewer opportunities for children to be involved in tests of drugs, but there's more opportunities for them to be in trials, for instance, looking at devices to measure gluten. And if you think about something like Dr. Fasano was just mentioning with the CD-GEM, these participants are actually recruited in utero. And so you can get all across the lifespan to participate in a celiac disease study. And we will learn a lot from all of these different types of participation. I think overall, there's been more of a push to try and move pediatric studies earlier, particularly adolescent studies. So across the board, and hopefully increasingly in celiac disease, we'll see more opportunities for younger people, particularly adolescents.
Good. Alessio, understandably, there's a lot of interest in a cure for celiac disease. Do you have an opinion as to the most promising approach that might lead to a cure in our lifetime?
Well, I don't have doubts that we will have a cure. I don't know when. That's where the only variable is. And the reason why I'm so confident is because we know so much about the pathogenesis of celiac disease compared to the other autoimmune diseases that I think that sooner or later we'll have a cure. The cure will be something in which, as you heard from all of three of us, will target the immune system that will need to be reprogrammed to tolerate gluten. And one is supposed to gluten to stay put, say, okay, that's fine, you're fine here. That is exactly what the vast majority of people, they do when they eat gluten. If you're not celiac or you don't have any gluten-related disorder, when you see gluten, you just stay put and deal with that. So that's probably what would be a cure, or what the cure would look like.
Yeah, I'm inclined to agree that that's where the action is. And so that's where the cure comes from. Amelie, is it always necessary to engage in a gluten challenge in order to be involved in a clinical trial of celiac disease?
Well, it depends on the goal of the treatment. Like Dr. Fasano and Jocelyn explained, some of the goal of therapies could be to reduce symptoms from accidental exposures to gluten. So if the treatment is to help you in real life with your symptoms while staying on a gluten-free diet, then the trial may not require that you eat gluten. And there's at least one trial like that is ongoing. However, if the goal of the medication is to eventually replace the gluten-free diet, one of the trial will evolve at some point to eat gluten, as we want to test the efficacy of the drug in that purpose.
Jocelyn, there are several questions about side effects of drugs and adverse events during testing of drugs. What's the approach? I think you touched on this in your talk.
That's a great question, and I definitely could have said more. So the general approach is that is to generally ask broad questions to elicit any symptom, and not just look for things that the investigators think may be a problem. And I think the classic example of this is actually not a celiac disease example, but Viagra, which was initially developed as a blood pressure drug, but the nurses who were involved in the trial noted that a lot of the men were reporting other side effects of the drug, which ultimately is why it ended up being not a blood pressure drug, but an erectile dysfunction drug. And so there's systematic collection of feedback on every system, and then also targeted collection of side effects if there's been something that's been identified in an earlier phase.
Good. Alessio, your crystal ball is asked for again. What do you think is going to be the next big news in celiac disease research?
Well, again, I think that if somebody would have told me 2 years ago what we know about celiac disease now, I would have said, you must be out of your mind. I really do believe that, epidemiological studies taught us that you're not born with celiac disease. You become celiac. You're born with a genetic predisposition. Remember, celiac disease is the only autoimmune disease for which we know the trigger. And until really the recent past, we really did believe that, eating gluten will be the moment in which you start the march towards celiac disease. Now we know that it can take 50 years eventually after the first exposure to gluten to develop celiac disease. So I believe the most exciting part is to understand that switch that I was telling you about. So in other words, how these genes, they are there, will be turned on or turned off to the point in which this will make, gluten an enemy rather than to be a friendly cohabitant. And I really do believe this will come from these longitudinal studies like the CDGEM that will really tell us this crosstalk between us and the ecosystem of the gut that will eventually create the problem. I think that this is the most exciting situation because, again, I'm saying something that people may have an issue with that. I don't think that autoimmune diseases is one way. So if we can turn off this switch and stop, this, celiac disease ongoing situation, I'm pretty sure that we will be able to do the same with multiple sclerosis, type 1 diabetes, rheumatoid arthritis, and so on and so forth. And I'm very convinced that celiac disease is the one that will bring us there.
Good. Amelie, can you comment on the risk of cancer in untreated or indeed in treated celiac disease?
Sorry, I was muted. So there are two types of GI cancer that can affect people with untreated celiac disease. So there are the lymphoma of the small intestine and an adenocarcinoma. So it's difficult to really know the natural history of everybody with untreated celiac disease because there may be people out there that are asymptomatic, that have celiac disease, that do not know. And we only see people in the medical settings because they are having symptoms or complications. So the risk estimate are not that good, but in general, it's overall rare. So there have been studies from Scandinavia, from Sweden, with their natural health registries looking at the risk of lymphoma, adenocarcinoma. So for instance, in 1 year, 3 out of 10,000 people in the general population will develop a lymphoma, while 7 patients with untreated celiac disease will. So yes, it's an increased risk, 3 versus 7, but it's over like 10,000 people. And for small bowel adenocarcinoma, it's even like rarer. So over 11 years, the rate of having a small bowel carcinoma among people with celiac disease was 6 for 10 people, but over the spectrum of 11 years, while compared to 2 over 10,000 people in the general population. There was still a trend towards having normal biopsies and a lower risk of developing carcinoma. So yes, we believe that in general, like having mucosal recovery significantly reduce your risk of developing a cancer. But again, the risk is present, but it's overall pretty small.
Okay. Alessio, a question that you've been asked many times: is there a connection between celiac disease and schizophrenia?
Well, one of the most fascinating points of the celiac disease story that we learn is that, in general, the inflammation materializes on the battlefield where the instigator, i.e. gluten, encounter the soldiers, i.e. the immune cells there, Amelie was discussing about, that are there technically to defend us, but in people without immunity, they point the weapon against our own body. What is also interesting in celiac disease, that even if it's a GI disorder, it's truly a systemic condition. So every single tissue organ may be attacked. Why? Because the soldiers can leave the battlefield and go anywhere, including the brain. It seems to be one of the most favorite places where they go. And when they go there, they can create what we call neuroinflammation. The same inflammation that we see in the gut, we see in the brain. And depending the entity on the inflammation and the location of the inflammation in the brain, you can develop different symptoms, from chronic fatigue or short memory loss, headaches, all the way to schizophrenia. So there is definitely this possibility. It's not frequent, but it has been described.
And I think probably a final question, Jocelyn, it's about gluten challenge. Do you have to have a gluten challenge to diagnose celiac disease? And is gluten challenge changing?
That's a great question. And I hope that soon the answer will be that we will have a way of diagnosing celiac disease in people who are on a gluten-free diet. Currently, the tests that we have work best when people are consuming gluten. And I think how much gluten for how long, if you're gluten challenging somebody for clinical purposes, is probably a matter of debate, but most would agree the more gluten, the more time, the more likely you are to be confident with the result of your biopsy. In a clinical trial, I think even with some of the studies that are happening or about to happen, we're seeing that there may be a period of several days where there's gluten consumption, and then a single dose of gluten, and then looking at the reaction to T cells might give some idea of whether these inflammatory T cells are present or whether there's more of these regulatory T cells that don't respond. So I think clinically, it's going to be individual. Talk to your doctor. In terms of research studies, I think that the amount of gluten is decreasing rather quickly as we learn more about celiac disease and how to measure response to gluten.
Mm-hmm. Alessio, a question about glutenases. Why do humans not make glutenases, and who does?
Well, actually, these endopeptidases or the glutenases are very weird, unusual enzymes. We don't have the need to that because we have, evolutionarily speaking, we are not meant to digest strange protein as gluten. Gluten is extremely rich in glutamine and proline, two amino acids that, again, require specific scissors or enzymes that we don't have. But bacteria, they do. They produce a fair amount of this endopeptidases because they have the need to for their own cycle, life cycle. And therefore, exploiting that approach by using the wisdom of microorganisms and producing this, endopeptidases will give us the luxury to do something that actually we are physiologically not capable to.
Thank you, Alessio and Amelie and Jocelyn. Thank you all for wonderful answers to those questions. And now, because of time, unfortunately, we don't have able to address some of the other questions. I'm going to turn back to Lee Graham to conclude the session.
Thank you, everybody. I always learn something in these things, and I hope all of you did too. I think it was terrific. As we mentioned before, a recording of today's webinar will be on the NCA website, probably in the next week or so. Meanwhile, stay tuned for more webinars starting back up in the fall of 2021. You can check the National Celiac website or sign up for our free newsletter to get the latest webinar schedule as soon as it is available. Until then, stay well and have a wonderful summer.